Thank you so much. It really is my pleasure to speak to you all today. And these are my disclosures. So I wanted to begin with a case, and this is a patient that we saw at McMaster University. And this is a 30-year-old woman who was 33 weeks pregnant. And she came to the hospital because she was having leg pain. And she also said yes when she was questioned. She said, yes, I've been feeling thirsty and I'm urinating more for maybe the past year. And her ionized calcium was 2.1 millimoles per liter. Corrected calcium was 4.02 or 16.1 milligrams per deciliter. I don't know if you're following the imperial or the SI units, but this was very high. And PTH was 147 picomoles per liter. So it was 40 times normal. Her vitamin D levels were low at 36 nanomoles per liter or 14 nanograms per mil. The alkaline phosphatase was very high. Her GFR was 60 and her magnesium was in the normal reference range. And we calculated the calcium to creatinine clearance ratio, and it was 0.05. And this is what her leg looked like. So you can see over here, over the distal femur, there was a large area of lucency involving the cortical and the trabecular bone. It was 6 by 3 centimeters with some aggressive features, an absence of a clear, well-defined margin, and there was cortical involvement. So it looked like it could be a brown tumor that can be seen with primary hyperparathyroidism. It could also be metastatic disease from parathyroid cancer because her calcium was very high and her PTH was very high. So those were some of the considerations, but other tumors or other metastatic lesions are also a possibility. So these are the guidelines that we published, and they came out in JBMR in 2022 with global contribution. And I wanted to begin by reminding everybody that when serum calcium goes down, it stimulates the calcium sensing receptor. So it is sensed by the calcium sensing receptor, and this will result in an increase in the synthesis and release of the parathyroid hormone. So when we have an increase in parathyroid hormone, this is detected by a decrease in the calcium sensing, in the decrease in the serum calcium, then PTH levels rise. And PTH increases renal calcium reabsorption. Every day we filter 10 grams of calcium through the kidney, 10 times what a normal person would take orally. And we reabsorb 9.8 grams of that calcium. So when calcium levels go down, PTH goes up, and we become more efficient in calcium reabsorption. And this happens within minutes. So this is how we're able to regulate our serum calcium, increase renal calcium reabsorption. And if that insult, the hypocalcemia, persists, then the next impact will be, over the course of hours, we will increase bone resorption, because PTH will bind to PTH receptors on the surface of osteoblasts and increase rank ligand expression and increase osteoclast formation, function, and survival, and cause bone resorption. And then with the bone resorption, there will be calcium and phosphate released into the circulation. One important point that I want to mention here is that when we increase calcium reabsorption through the kidney, the PTH also has a phosphaturic effect. So it increases phosphate renal excretion. And it's a beautifully designed system because we reduce phosphate levels in this stage, because in the next stage, there will be release of calcium and phosphate into the circulation. The next impact of PTH over days is an increase in the hydroxylation of vitamin D. And so we will take 25D and stimulate the hydroxylation to form 125D, and then this will result in increased calcium and phosphate absorption from the bowel. So those three effects will result in reestablishment of normal serum calcium. Now, in primary hyperparathyroidism, we can have primary hyperparathyroidism. 85% of those cases are because of a parathyroid adenoma. Or it could be due to hyperplasia. 15% could be because of hyperplasia. And rarely do we have cancer. Now, what we've seen is that the expression of the calcium sensing receptors is decreased in adenomas and in hyperplasia. So there are fewer calcium sensing receptors. And because the receptors are decreased, when serum calcium goes up, it will turn off PTH. But if we don't have enough calcium sensing receptors, PTH will not be turned off. So the parathyroid tissue is less responsive to hypercalcemia. And that is the mechanism for the hypercalcemia and the fact that PTH continues to be elevated. It's because there is a decrease in the expression of calcium sensing receptors in adenomatous and hyperplastic tissue. So how do we make the diagnosis? We always have to correct calcium for albumin because half of the calcium is bound to albumin. So if we have high levels of albumin, then we have to correct for that. So the formula is calcium corrected is the calcium measured plus 40 minus the albumin times 0.02. So if the albumin is high, we're going to correct and reduce our the measured calcium. So our corrected calcium will be lower. And if the calcium is low, we have to take that into consideration and we'll be adding, and we will be adding it to correct it. So we have to have a corrected calcium. If the calcium is high, the normal response is for PTH to go down. So if PTH is not going down, that means the parathyroid tissue is pathologic. It could be adenoma, it could be hyperplasia, or rarely hypercalcemia. And we would call this PTH dependent hypercalcemia because the normal response in the presence of high calcium is to suppress PTH. So if PTH is not low or low normal, that is PTH dependent hypercalcemia. We have to make sure that our patient isn't taking drugs that can look like primary hyperparathyroidism, such as hydrochlorothiazide. What hydrochlorothiazide does is it enhances renal calcium reabsorption. And so it will give the presence of hypercalcemia. It can result in elevations in calcium, and it can also result in elevations in PTH. And what lithium does is it changes the set point for the suppression of PTH by calcium. And so these drugs can mimic primary hyperparathyroidism. And it is important for us to make sure that our patient is not taking hydrochlorothiazide. If they are, we have to stop it. It might be with the hypertensive medication. We have to stop it and then repeat the lab test 6 to 8 weeks later and see if the hypercalcemia has resolved. If the patient is on lithium, it can be hard to take them off lithium if they're taking it for manic depressive illness. And so we have to take that into consideration. We also calculate our patient's calcium to creatinine clearance ratio. And this is calculated by looking at the urine calcium, 24-hour urine calcium, multiplied by the plasma creatinine, and divided by the urine creatinine multiplied by the corrected plasma calcium. If this ratio is more than 0.02, then it is probable that our patient has primary hyperparathyroidism. But we can have a situation called FHH, familial hypocalciuric hypercalcemia, where there is an inactivating mutation in the calcium sensing receptor. And the receptor, there's a mutation in the gene, so the receptor is less sensitive to calcium. So when calcium levels go up, it's sensed by the calcium sensing receptor and it turns off PTH. And so when we have a less sensitive receptor, PTH is not going to be turned off. And so we will have a high calcium with a high PTH. But remember, the same abnormal calcium sensing receptor is present in the kidney. And in the kidney, when calcium levels go up, this increases urine calcium excretion. But when the receptor has a mutation, and there's a mutation in the gene, so the receptor is less sensitive to calcium, calcium levels go up and urine calcium does not go up. And so this results in relative hypocalciuria. And patients with FHH will have a calcium to creatinine clearance ratio that is less than 0.01. Now, if it was 100%, it would be very easy, but it's not 100%. There's a gray zone, and there is an overlap between 0.01 and 0.02. And 40% of people with primary hyperparathyroidism will have a calcium to creatinine clearance ratio in the gray zone. And 40% of people with FHH have a calcium to creatinine clearance ratio, which is in the gray zone. So we have to take that into consideration. And in fact, 10% of patients with FHH can have a calcium to creatinine clearance ratio, which is higher than 0.02, the same as what we see with primary hyperparathyroidism. And we have patients who have had DNA analysis and they have a confirmed mutation in the calcium sensing receptor gene. And they have a calcium to creatinine clearance ratio, which is greater than 0.02. Now, it's not common. It's only 10%. 90% will be either in the gray zone or less than 0.01. And 20% of primary hyperparathyroidism patients can have a calcium to creatinine clearance ratio, which is even lower than 0.01. So it's not 100%. Now, there are other reasons why a patient can have a low calcium to creatinine clearance ratio. And some of those reasons are low vitamin D levels, low calcium intake. It can also be seen in blacks in comparison to whites. Blacks can have a lower calcium to creatinine clearance ratio. In these people, we may want to do DNA studies and confirm what is our underlying diagnosis. But be concerned about the possibility of FHH if your patient has lifelong hypercalcemia, if they're younger, if they have a positive family history. And the DNA analysis that we would do would be for 3 genes, the calcium sensing receptor gene, the GNA11 gene, and the AP2S1 gene, because they're 3 forms of FHH. This is what parathyroid bone disease looks like. If we have patients who have very high PTH levels, it will cause osteoclastomas, which are brown tumors. It causes this osteitis fibrosa cystica that is not commonly seen, but this is what our patient had. That young pregnant woman who came in with the leg pain, she has osteitis fibrosa cystica. She actually had a brown tumor in the distal femur. And we can also see the salt and pepper skull with diffuse demineralization of the skull. So when we evaluate our patient, we have to measure the lab profile. We check the calcium. Ionized calcium also should be evaluated. Check phosphate, check PTH, vitamin D, and renal function. And look at the bone density. And because in primary hyperparathyroidism, we can have more significant reduction in bone density at the distal 1/3 radial site, we recommend that the lumbar spine, the femoral neck, the total hip, and the 1/3 radial site be evaluated. And we also recommend that spine imaging be done, vertebral fracture assessment, or vertebral x-rays to see if they are vertebral compression fractures, because we know that a significant number of vertebral fractures can be silent. Now, what is the effect of high PTH on the skeleton? Well, the longest study to evaluate this is the study completed by Pretorius and colleagues, and this was published in the Annals of Internal Medicine, and this was 10-year prospective data, randomized controlled trial of 191 patients who had asymptomatic mild primary hyperparathyroidism. So they had mild hypercalcemia with corrected calcium between 2.6 and 2.8. So you can see that their calcium levels were not very high, and they were between the ages of 50 and 80. And if they had chronic kidney disease or kidney stones, they were not included in the study. And they had spine x-rays done at baseline, 2, 5, and 10 years. And what was seen was, in comparison to the people who had parathyroidectomy, the ones who were observed with mild primary hyperparathyroidism, there was no impact on cardiovascular or cerebrovascular events. And these people did fairly well. They didn't have to go for surgery. Their mortality was low, and also fractures were no different. But there was one issue, and that is that there was a significant withdrawal rate. There was like 23 patients withdrew in 190 odd patients in the parathyroidectomy group, and 27 withdrew in the observation group. So it had about a quarter of the patients withdrawing. But from the data that was obtained, we can say that medical observation appears to be safe, and parathyroidectomy does not improve quality of life, and observation does not worsen quality of life in patients who have mild disease. This does not apply to people who have chronic kidney disease. This does not apply to people who've had more significant hypercalcemia, because if they had kidney stones or chronic kidney disease, they were not included. So it doesn't apply to those people, and it doesn't apply to people who have more significant hypercalcemia. But it does apply to older patients who have mild disease. Maybe we can just watch them and follow them if they don't want to have surgery. We do need to evaluate renal function, and we need to look to see if they've had kidney stones with renal ultrasound, and do a 24-hour urine for calcium, oxalate, citrate, and uric acid, looking for other risk factors for renal stones. Now, it is important to recognize that we are seeing patients present with primary hyperparathyroidism at an earlier stage. So today, patients are not presenting with overt disease. They're presenting with mild hypercalcemia. Previous decades, 80% of people would have had a kidney stone in primary hyperparathyroidism. But now, 7 to 20% will have a kidney stone. And in the normal population, only 1.6% have kidney stones. Kidney stones are seen more commonly in young men with primary hyperparathyroidism. Following parathyroidectomy, the risk of kidney stones goes down, but it does not normalize. So we do look at the whole stone profile: urine calcium, 24-hour, oxalate, citric acid, cysteine, and urine pH. And we have data showing us that people who have chronic kidney disease with GFR below 70 mils per minute are more likely to have more severe bone disease. And parathyroidectomy appears to protect from further declines in renal function. So let's move on now and talk about asymptomatic primary hyperparathyroidism. Our patient may have asymptomatic primary hyperparathyroidism with target organ involvement, which is osteoporosis, fragility fractures, or kidney involvement with renal impairment, nephrocalcinosis, calcification of the renal parenchyma, or kidney stones, or they may not have any target organ involvement. There is another form of primary hyperparathyroidism called normocalcemic primary hyperparathyroidism. And in this situation, we have to exclude a physiologic rise in PTH. So how do we diagnose this? The calcium is always normal, and PTH is elevated. So we have to make sure that this isn't because of a physiologic rise in PTH. Is it because of low vitamin D levels? Is it because of impairment in renal function? Is it because of medications? As we mentioned, thiazide diuretics can result in an elevation in PTH, or lithium. Is it because of anti-resorptive therapy? And often we see this with denosumab use. Is it because our patient has hypercalciuria or malabsorptive states, that there's a physiologic rise in PTH? We have to exclude this before we make the diagnosis. And when we make the diagnosis of primary hyperparathyroidism, we can follow these people. We do not recommend surgery for people with normal calcemic hyperparathyroidism. We do recommend DNA analysis to exclude multiple endocrine neoplasia and the 3 forms of FHH. Remember that 10% of patients with primary hyperparathyroidism, if they're under 45, may have a mutation in the MEN1 gene, the CDC73 gene with hyperparathyroidism jaw tumor syndrome, or the calcium sensing receptor gene. Okay, so who goes for surgery? If there is significant hypercalcemia, they can go for surgery. If they have osteoporosis, they can go for surgery. If they have chronic kidney disease, they can go for surgery. If they've had kidney stones or nephrocalcinosis or hypercalciuria, they can go for surgery. If they're under the age of 50, they can go for surgery because younger age is a recommendation for surgery. And how does this compare to the previous recommendations? We're basically emphasizing the previous recommendations because we have more data to support this, but we're also emphasizing the fact that we can recommend surgery even by VFA. If there is evidence of vertebral fracture, we would recommend surgery. So what is new are the recommendations and options for medical intervention and the recommendations for pregnancy. And I will, just in view of the limited time, remind everybody that bisphosphonates can provide skeletal protection. This is the result of our randomized controlled trial showing us that with alendronate, we see improvements in bone density in comparison to placebo at the spine and the total hip. But bisphosphonates do not lower calcium or PTH. And what about cinacalcet? So in the randomized controlled trial phase 3 study, we demonstrated that cinacalcet is a calcium mimetic agent, and cinacalcet can act to lower calcium and PTH levels, and it will reduce PTH and calcium. It's like a chemical parathyroidectomy. We start at 30 milligrams BID and adjust the dose. You could go up to 90 milligrams TID, and we demonstrated that cinacalcet will drop serum calcium and normalize it. And then when placebo was switched, excuse me, to cinacalcet, the calcium levels normalized also. So we recommend that these are the medical options for the management of primary hyperparathyroidism. In pregnancy, it is important to remember that there is endogenous production of PTHrP, and this can have a further impact on PTH levels. It can lower PTH levels, so we do need to take that into consideration. In a pregnant woman, we can do renal ultrasound to determine where this adenoma may be. And we can also do CT. CT of the neck is believed to be safe with very low dose fetal radiation exposure. In pregnancy, we recommend hydration, discontinue calcium supplements and hydrochlorothiazide and lithium if possible, correct vitamin D. The only drug that we can safely use in pregnancy is calcitonin. Cinacalcet has been used in a few case reports. There's several case reports, and neonatal hypocalcemia was described in one case report. These drugs are not recommended. Bisphosphonates, denosumab, and phosphate are not recommended. And we did say that surgery should be considered in pregnancy, ideally in the second trimester. But in our patient, we did surgery, even though she was in the third trimester, because her hypercalcemia was so severe. And she had a huge parathyroid adenoma. And so we actually hydrated her, gave her cinacalcet, sent her for surgery, and she actually had a parathyroid adenoma. So the take-home message is that parathyroidectomy is always an attractive option for asymptomatic primary hyperparathyroidism because it will correct the problem. It will allow the bone to heal. It will reduce the risk of kidney stones. But people with mild disease who are older, who don't want to have surgery, could potentially be followed. Patients who don't want to have surgery can be given skeletal protection with nitrogen-containing bisphosphonates or denosumab. Cinacalcet can be given orally to lower PTH and calcium. And during pregnancy, we do consider parathyroidectomy if they have severe hypercalcemia. So with that, I'd like to thank you for your attention and answer any questions that you have.
Thanks a lot to Professor Aliya Khan for this high caloric lecture. Thanks a lot for your our accepting our invitation. And I apologize because I am not introducing myself for the lecture. I am Professor Ihab Salim, Professor of Diabetes Endocrinology, Zagazig University. I come rapidly from my clinic because now now we are few minutes before the sunset breakfast. We are fasting in Ramadan. And
Yes,
so
we are also.
I come rapidly from my clinic to be in the time. I have a rapid question, not just to you. The first question: what about your opinion about the use of radiofrequency ablation in parathyroid adenoma? Radiofrequency ablation of microwave successfully used in thyroid nodule. Some
Yeah.
report will mention this issue. What's your opinion about this issue?
Well, it does need more investigation, but right now, if you have an experienced surgeon, the surgical approach is very, very effective with very high surgical success rates. So
Yes.
if the patient can go for surgery, that would be our recommendation. We
Yes.
did not make any recommendations on radioactive iodine ablation, and we do not recommend that. And
Not radioactive iodine ablation, radio frequency.
radio frequency, we don't recommend that. Yeah, radio frequency ablation is not recommended right now. We do not have enough evidence to make recommendations for that, but we do recommend surgery or medical options.
Yes,
That is what is recommended at this
yes.
time.
I know this is not recommended, but ask you to your opinion about the newly
Yes,
introduced, as is
yes.
it newly introduced in thyroid nodule, and they make some success for patient who are unfit for surgery. Another alternative for surgery. Some patient we have a problem in localization of adenoma.
Yes. So what we would recommend, so with the sestimate scanning, as you know, the
Yes.
sensitivity and specificity is not adequate. And so we are now moving away from that and basically going with CT imaging.
CT
So
imaging.
4D CT imaging is better, and this is more effective in guiding the surgical approach to determine
Yes.
if minimally invasive procedure is going to be beneficial instead of a total open parathyroidectomy. But we would still recommend that approach. Even if the imaging is not helpful, the CT imaging is usually helpful.
Yes. Yesterday, I have patient with multiple endocrine neoplasia type 1, have a parathyroid adenoma and pituitary adenoma, and the patient refusing surgery. And I suggest Cincalcet. For how long we can add the medical therapy?
Yeah.
Calcinomimetic by Cincalcet, the maximum dose, and for how long?
Well, the patient could continue on cinacalcet for several years. It would be no problem. The only problem is the cost. It is expensive in
Yes.
North America. I don't know if it's expensive in your country as well.
Yes, we try to do an insurance here. Yes.
Yeah. So
take it
that
from
is
the
the
insurance.
biggest limitation. But we can also combine cinacalcet with denosumab. So with denosumab
Yes.
provides skeletal protection, and with cinacalcet lower the calcium and the PTH levels.
Yes. What's your opinion about the indication of use of ionized calcium? What's the best indication for using ionized calcium in our investigation or the diagnosis?
We always like to do an ionized calcium to confirm that the patient does have hypercalcemia, and use the pH adjusted ionized calcium. It's always helpful to ensure that we don't have, myeloma or paraproteins that could be contributing to a false elevation in the measured calcium. So an ionized calcium is always useful.
You prefer to do the both total calcium,
Yes.
ionized calcium?
Yes, we do both. And there was a nice study that was published in JCENM showing that in early primary hyperparathyroidism, the ionized calcium can be elevated earlier than the elevations in the corrected calcium. And we see that often, that the ionized calcium will be up, and then the total corrected calcium will go up later in more advanced disease.
Yes. Are you do vitamin D routinely before you do surgical treatment for parathyroid adenoma?
We do correct vitamin D. Yes, we do
First,
that.
yes.
And we correct the vitamin D. If it's not an emergency, we would correct it, and then send them for surgery. But it doesn't necessarily need to have the surgery delayed for that.
Yes.
But we know that the people who have vitamin D insufficiency will have another cause for the parathyroid adenoma to become larger. And people who have inadequate levels of vitamin D have larger parathyroid tumors, and they're more likely to have hungry bone syndrome. So it is a good idea to correct the vitamin D.
Vitamin D first. Thanks a lot, Professor Aliya Khan. I am happy. I enjoy much this lecture. Thanks for your kind accepting our invitation, and I hope that you see in Egypt. Looking forward to seeing Egypt in the near future, inshallah. Thanks a lot.
Inshallah. Thank you so much, Professor
Thanks.
Salim. It was my pleasure to meet you.
Pleasure to see you in the end of bridge this year, inshallah.
Inshallah. Okay.
Inshallah.
Jazakallahu
Thanks a lot.
khairan.
Thanks a lot.
Assalamu
Thanks.
alaikum.